Okay, this is part 3 of the mechanical ventilation lecture. This is a relatively shorter lecture. Okay, we're going to discuss the principles of weaning from mechanical ventilation. Well, how does the clinical team decide when the patient is ready to be removed from mechanical ventilation, or which also corresponds to whether the artificial airway can be removed, okay, or the endotracheal tube. And also a brief discussion on the physiological effects and complications of mechanical ventilation on the body system, particularly the cardiovascular and the pulmonary systems. Again, the required readings. So when we talk about weaning, we're talking about weaning off mechanical ventilation. It may not necessarily mean it's the removal of an artificial airway, but if a person is intubated in the ICU on an endotracheal tube, and if the tube was placed in the beginning for mechanical ventilation, then weaning of mechanical ventilation also equates extubation, the removal of the tube. Extubation. To extubate means to remove the tube, the artificial airway. Okay. So weaning means the process of getting the patient off the machine. Okay, so discontinuation of mechanical ventilation. So these are some of the criteria that the physicians and the team will decide whether the person is ready. Okay? Number one, the reasons and the causes that got the patient to be on the mechanical ventilator needs to be reversed or checked. Okay, sometimes certain causes may not be fully reversible, but at least there should be evidence that it should not be, whatever underlying cause should not be causing the patient to require mechanical ventilation any longer. Okay? The patient must be able to adequately oxygenate. Okay, so we use the PF ratio to determine the oxygenation index. The PEP requirement should be as low as possible. Likewise, for the FiO2 requirements to be as low as possible. Okay, this is important because when you remove the endotracheal tube, or you turn off the mechanical ventilation and remove the endotracheal tube, there's no longer the PEP that you can put in. Okay, the patient will still can still receive supplementary oxygen through an oxygen mask or nasal cannula, and so therefore it is important that the patient's oxygenation requirements is actually on the lowest. Okay. The patient should be hemodynamically stable, okay, because the moment the machine is removed, the positive pressure within the lungs are removed, then the effects on the cardiovascular system can make a difference. This point about able to initiate an inspiratory effort is a no-brainer, okay? And that the patient must be able to breathe spontaneously on a spontaneous breathing mode. Okay, all that makes common sense. So what does a spontaneous breathing trial mean? So for what does a spontaneous breathing trial mean? Most of the time is this: pressure support ventilation. And the most common settings to put a patient for spontaneous breathing trial for PSV is a pressure support of 5, and then the pressures and the PEP, the baseline pressure of 5. Okay, which is usually the arbitrary PEP that I've talked about. And then the FiO2 should be as low as possible. Okay, less than 0.5. Okay, sometimes the team may put a person's FiO2 to even at room at 0.21. Really depends on the patient's oxygenation needs. Okay, there's also, so they put the patient on a PSV for 1 hour or 2 hours, depending on the protocol or the practice guidelines of the setting, and then they will take an ABG to see whether the patient is ventilating well or oxygenating well. If the patient is doing okay, then they will say, okay, let's pull out the tube, stop the mechanical ventilator, and put the patient on a face mask or nasal cannula. Okay. The other way, which is not a common way of weaning, especially, is the T-piece weaning. Okay. T-piece weaning is usually used for patients who have difficulty weaning. They are not the very straightforward patients. Very straightforward cases, put the patient on PSV, say the patient can breathe spontaneously, doing well, they extubate. Okay, for some patients who have been dependent on mechanical ventilation for whatever reason, and they have a very long journey of weaning, then the T-piece weaning might be used. It's not commonly used. I've probably, for the last 5 years, I've probably only seen one used, and is really for a patient who has been in the ICU for a very long time and has difficulty weaning. So what this does is, the team will do is they will remove the patient from the endotracheal tube, and then this part will be placed on the endotracheal tube. Okay, the ETT. And then the patient literally then breathes through this. Okay, the air entrainment nebulizer works like a venturi mask and delivers the FiO2. Okay, then this open reservoir means it ensures that when the patient takes in the breath, it ensures the FiO2 delivery. Okay, so in other words, you are getting the patient to breathe at atmospheric pressure. So that's TP's weaning. Okay, again, not commonly used. Most common is PSV. Okay, sometimes the team, if the patient is on PSV, they may turn off the pressure support. So if pressure support equals 0 with only the PEP, then that's CPAP. That can also be used as a spontaneous breathing trial. Okay, but as I've mentioned, because the pressure support was initially created to overcome the work of breathing imposed by the airway resistance of the circuit as well as ETT, so most clinicians will use PSV as the preferred spontaneous breathing trial mode. Okay. So what's your role? What's our role in mechanical ventilation weaning? Okay, we can start as soon as the patient is medically stable, assess the patient's potential in terms of rehab, and we also can initiate mobilization, whether it's sitting on the edge of bed or sitting out of bed and everything. So this will probably be discussed in Meredith's lecture on physiotherapy management in the critical care setting. Okay, you already know we will help with airway secretion clearance. Okay, if necessary, in respiratory or inspiratory muscle training. While the patient is on mechanical ventilator, we may get the patient to mobilize and even walk. Okay, to also as a form of respiratory muscle training and also total body training or rehabilitation. Okay, in some settings, you may be the one helping with the extubation or helping to identify whether the patient is ready for extubation. So therefore, some of the things that the doctors might find out from you, the team might find out from you is does the patient still have a lot of airway secretions? Can the patient initiate the cough? Do you think the patient will be able to cough effectively after the tube is being removed? Of course, you can't assess the patient's cough effectiveness when the artificial airway is still in place. The patient can initiate a cough, but because of the presence of the artificial airway, you probably won't be able to really know whether the patient can effectively cough. So this is an inference on implication. Okay, and also then the assessment of the neurological status, which the team will do. You will also do your GCS or your neurological state assessment while you are assessing the patient at every patient encounter, but the team will also do that as well. Okay, so as I said, in some settings, you might be the one initiating non-invasive ventilation, so this might happen. You may also be part of the tracheostomy team, so you may also be helping with the tracheostomy team weaning as well. Okay, and for some patients with difficulty weaning, especially patients with long-standing chronic respiratory dysfunction or respiratory lung diseases like COPD, then you may also help to identify and inform the team that the patient might not be that ready for extubation at this point in time, or may need a longer period of time, or may suggest changes in medical management to help the patient in terms of, say, airway clearance management. Okay. So some points to remember about weaning of mechanical ventilation. A spontaneous breathing trial is safe and effective in determining whether the patient can be weaned off mechanical ventilation. It also tells the team whether the patient can breathe on his or her own when the mechanical ventilation is removed. Okay. You may also do other assessments, but research have shown that a lot of other measurements may not be may not add a lot of value in terms of assessing whether the patient has weaning potential. But of course, the stronger the person is, and the less work of breathing there is, the better it is in terms of the patient being able to breathe on him or on their own without the support. Okay, as I mentioned before, the spontaneous breathing trial is done 30 minutes, 1 hour, 2 hours, and then ABG is done, the clinical assessment is done, then the artificial airway is removed or extubation is done, and then the mechanical ventilation is stopped. So last few slides on the effects of mechanical ventilation on the body. So this graphic tells you some of the effects on some of the effects of mechanical ventilation on the various systems, the pulmonary, cardiovascular, renal, and cerebral. We're going to really just focus a little bit more on the pulmonary system and the cardiovascular system. So some of the explanation, VAP stands for ventilator acquired pneumonia. So this is pneumonia that is acquired when the patient is on mechanical ventilation. So this is a hospital acquired pneumonia or nosocomial pneumonia. Okay? Mainly because of the presence of the artificial airway as well as management of secretions. Sometimes it's just a matter of oral secretions that may have all the microbes that seeps past the endotracheal tube and enters the lungs and therefore becomes pathologic. VILI means ventilator-induced lung injury, and this has to do with volume trauma, or barotrauma. So VILI is the result of barotrauma and volume trauma. So we're talking about ventilator-induced lung injury where lung units are being over-distended, and then they suddenly deflate. So they're subjected to a lot of tension forces as a result of too much pressure or too much volume. Okay, so the team needs to monitor that as well. Then of course there are other airway related types where the placement of the artificial airway, the presence of the artificial airway that can cause many other issues. So that's already covered in the artificial airway lecture. Cardiovascular, because of the positive pressure that is imposed within the respiratory system from the mechanical ventilator, there is reduced preload, okay, because the pressure within the lungs impedes the return of the blood in the veins, so decreased venous return, and therefore preload decreases. And because preload is decreased, then therefore cardiac output is decreased. Okay, so whatever is returned is less, then whatever you can give out is also less. Okay, and the heart is within the thoracic cavity, surrounded by also the lungs. So when you have the lungs receive positive pressure, it kind of also compresses on the aorta. There's also positive pressure on the heart, and therefore there is increased afterload. Okay, the heart needs to beat a little bit harder to overcome this afterload in order to get blood out into the aorta and into the body system. Okay. Then because of the relationship here on the effects of cardiovascular in terms of cardiac output, then there's also decreased blood supply to the kidneys, and therefore this can happen. Okay, decreased glomerular filtration. And then the last part has to do with also also about decreased blood flow. So the body might sense that they may not have enough blood volume, and therefore may increase ADH, okay, which means reducing urine output. Brain-wise, again, blood flow, cerebral pressure. I will talk about this in also lecture 5 on neurologic critical care. Okay, so we'll leave that to that lecture. So positive pressure on the lungs, okay, it reverses the ventilation gradient. So think about when you are anesthetized and you are paralyzed and therefore you're not using your diaphragm, then your diaphragm becomes passive. Okay. Now, like all gas and fluids always take the path of least resistance. So all the more when you're receiving positive pressure ventilation, same thing, the gas will still take the path of least resistance. Now, because your diaphragm is passive, and not moving, not creating that negative pressure within your lungs, then the path of least resistance is actually to the upper region of your thorax. So the lung units in the upper region of your thorax, when you are upright or seated somewhat upright, or lying in bed about 30 degrees head up, the lung units in the upper region are relatively more open and less resistant. So therefore, air will go to the upper region compared to the lower region, which is most of the time compressed by either the diaphragm, the abdominal content being pushed up against the diaphragm, as well as also perfusion in the lower region of the lungs. We've already talked about this VAP, okay, ventilator-acquired pneumonia, and this refers to pneumonia acquired 48 hours after intubation or the initiation of mechanical ventilation. VILI, the lung injury that resembles ARDS. We'll talk about ARDS in lecture 5. Barotrauma, the meaning volume trauma, because of volume, and then we also talked about airway-related issues. Okay. Of course, airway-related issues sometimes can't. You can prevent, but if it's during the process of placing the artificial airway, then it's something that at least as a physio we can't do much about it. It has to do with the clinician's technique. All the others above, there are tactics to prevent. Okay, proper settings to prevent too much pressure, to prevent too much volume, and also there are tactics to try to prevent VAP. Okay, one of them would be keeping the patient 30 degrees head up, and also ensuring oral hygiene. Okay, some of the positive effects on the heart, we've already talked about pressure in the lungs, the PEP, positive pressure, will decrease your right ventricular and diastolic pressure because of the decrease in venous return. And therefore, your right ventricular output decreases. Your right ventricular output decreases means your left ventricular return is also decreased. So the left ventricular and diastolic pressure also decreases. Then your left ventricular output decreases, or the cardiac output decreases. So your overall blood pressure might decrease. Okay, and it's because of all these the systemic arterial pressure decreases, and therefore it leads to the cerebral and renal effects. Some of. Yep. In addition to all this, okay, there's also the stress hormones that are being created or generated as a result of the pressure, and that can also cause, increased pulmonary resistance, and also your left ventricular compliance might drop depending on how much pressure is within the lungs. Okay. So PEEP reduces glomerular filtration. Is not direct. It has to do with the pressure that was illustrated in the previous slide. Okay, so this is just something to take note. Okay, not that relevant at this point in time, but if you do practice in the ICU, then you will need to really know a lot more about what the patient goes through in the ICU, not just mechanical ventilation. Okay. So last slide, summarizing everything about what you need to know about mechanical ventilation. Okay, it's your responsibility to do no harm when you are managing patients or clients on mechanical ventilation. So you need to know the effects of positive pressure ventilation on your patient, and how your management in terms of physiotherapy how they interact with when the patient is receiving mechanical ventilation. So therefore, you need to know the modes and the types of breaths that the patient is receiving in order to determine what you can do with the patient. Okay, this is just something that is somewhat related to the last few slides in terms of the effects of positive pressure on the heart as well as the cardiovascular system. Okay, hypotension can occur, but is systemic, is rarely occur, provided that the patient's compensatory mechanisms are intact. Of course, if they are not intact because of whatever pathologic processes the patient is going through, then the patient might be put on inotropes that helps to increase the patient's blood pressure. Okay, So that wraps up the lecture on. Okay, so that's it. I've spent a little more time explaining in the video recordings. I hope it will help you with understanding the concepts of mechanical ventilation. So please do review the recordings and the materials before the lab, and then be prepared to ask questions. Then I hope I'll be able to use the mechanical ventilator in the lab to help you understand the concepts. Okay, thank you.